evening, everyone. I'm Pallavi Jain. I'm the lead for YO.DH, which is Youth Ownership of Digital Health. And welcome to our webinar, The Role of Telemedicine in Expanding Access to Healthcare, a presentation by Charcha. Charcha is an online forum hosting webinars with leaders, entrepreneurs, and young professionals in the digital health space, fostering open conversations on the latest developments and future actions happening in the sector. Youth or YO.DH is a volunteer-led community of digital health professionals under the age of 35 who aspire to be the next generation of leaders driving change in the digital health space. Our vision is to empower young professionals in the digital health sector to lead the community. If you're not yet a member of YO.DH, I will encourage all of you to become a member of the community. And, there are a bunch of things that we offer, including Charcha. So it'd be absolutely wonderful to have all of you as a part of our community. We will shortly be sharing a link on our chat, and all of you will be able to click on that link and can become our members and follow us on social media. In case you may have any questions while the webinar is going on, I request all of you to use the Q&A function and you can put in your questions. And towards the end of our discussion, with time permissible, we'll try and take up as many questions as we can. So today we have with us Abhishek Mishra, who is a program officer at Path and who comes with 6 years of experience in the digital health sector. He is passionate about leveraging technology to improve the quality and accessibility of healthcare services around the world. Abhishek will be moderating our discussion for today. Abhishek, welcome and over to you.
All right. So as the name suggests itself, we are covering one of the topic from this whole digital health space, the telemedicine. And as universal health coverage has been the fundamental goal for many of those countries when pushing for health systems, we aim to bring the access to quality and healthcare regardless of income and social status. India also aims to do the same and achieve USC ASAP. But with the country with more than 1 billion people, health needs a challenge, not to mentioning treating rare and complex diseases. But Indian government goal to making access to care universal by 2030 will require a lot of creativity, lot of innovation, and lot of strategic planning. But what happened? There was a lot of change since COVID. While it became a health problem, it also provided one advantage: acceptance of digital. Digital slowly started getting accepted not only by the health sector provider, administration, but also the users. The patients started accepting COVID, digital. And one of the piece of this digital, as mentioned, is telemedicine. So in today's discussion, we have representation from a public sector, private sector, and service provider who will take their own journey of telemedicine, how that has changed the health ecosystem, the adoption of digital health technology pre and post COVID, as well as where they see the future will look like. So I'm just going to quickly introduce our speakers today. We have with us Jagdeep Gambhir. He is alumnus of ISB Hyderabad and is a visionary co-founder and CEO of Karma Primary Healthcare, a company dedicated to transforming the landscape of rural healthcare through digital innovation since 2014. Karma Primary Healthcare provides affordable, accessible, and quality primary healthcare to rural and semi-urban India using a judicious mix of technology and on-ground intervention to improve health outcomes. Karma operates e-doctor clinics providing nurse-assisted online medical consultation by qualified doctors, diagnostic services, and referral to secondary and tertiary care. With a deep-seated belief in the power of technology, Jagdeep is trying to bridge the urban-rural divide and solve the problem of lack of access to quality and affordable healthcare, lack of awareness to seek timely healthcare services, and shortage of qualified doctors. Welcome, Dr. Jagdeep. We also have Dr. Haleema Yezdani with us. Dr. Haleema Yezdani is a general physician and diabetologist with 20 years of experience, and since last 8 years have been working as teleconsultant. She is member of Telemedicine Society of India and vice president of HIMSS. Dr. Haleema was one of the first few doctors to practice telemedicine, and as a corona warrior, she treated more than 7,000 patients during the pandemic. Amazing feat, Dr. Haleema, and that was also on a pro bono basis. She is also recipient of more than 20 prestigious awards for her dedication to telemedicine and was the only Indian resident to be featured in the book Top 100 Welcome 100 Women of Future, Volume 2. Amazing, and welcome, Dr. Haleema Yezdani. We also have Rajesh Kaushik, Joint Director, CDAC Mohali. And probably as soon as you hear CDAC or eSanjeevani, they kind of reference to each other. So Rajesh Kaushik is Joint Director of the Center of Development of Advanced Computing in Mohali. He is also known for his technical expertise and noteworthy contribution to various research projects at CDAC Mohali, which is also the Center for Health Informatics. CDAC is one of the India premier R&D organization under MIT and has designed several health informatics technology, including eSanjeevani, also known as the largest telemedicine or teleconsultation platform of the world. So, welcoming all our panelists, and hopefully we will be having a great discussion today in and around telemedicine. So let's start with each of our panelists to introduce themselves and maybe 2 lines. What do they mean by telemedicine? So, Dr. Jagdeep.
Hi, thank you, Abhishek. First of all, thank you, Abhishek, Pallavi, and the entire Path team for inviting me and letting us share our experience. And good evening to everyone. One correction: I am not a doctor, so there is a space for non-doctors in digital health as well. So I am not a qualified medical doctor. So yeah, I'm Jagdeep. Um, you know, I'm a founder of Karma Healthcare. We are a social enterprise working in the area of enabling access to quality healthcare in rural and semi-urban India. As all of us are aware, there is a shortage of doctors and access to quality healthcare in rural India. There are public sector interventions, but there is data to suggest that a lot of people still seek care on the private side. So our intervention is that how do you actually provide digital health solutions to people who seek care on the private side as well. The main focus of our model is a paramedic assisted digital health model. So we operate e-doctor clinics in rural India. These are physical clinics which are manned by a paramedical staff. A patient comes in, and gets a consultation with a range of doctors who are available online. We currently provide general physician as well as 9 specialties and have about 50 clinics in 7 states in the country, all of these operating in the private sector. So, the core, work of ours is mostly on the nurse assisted or a paramedic assisted, right? So when we look at telemedicine, there are multiple definitions. You can do telemedicine directly on a mobile phone. You can do telemedicine on a doctor to another doctor consultation. Ours is a nurse assisted telemedicine model, which we think kind of addresses a need of access to care in the geographies where we work. So for us, telemedicine, to your question, Abhishek, means that how do you actually enable the entire comprehensive service delivery of healthcare. So, telemedicine, not just talking to a doctor over a video call, it is much more than that. How do you actually provide medicine? How do you, gather the patient history? How do you provide diagnostics, right? So, at the end of the day, the overall objective is improved health outcomes, right, through improved health access. Telemedicine is a medium. Telemedicine is one of the mediums, and that's how, we kind of look at it.
Dr. Haleema.
Okay, hi, hello everyone, and thank you for getting me on board in this panel. It's really wonderful to be among the great panelists who are here. Mr. Jagdeep and Mr. Rajesh, very nice to meet you in this panel discussion. So the first question that you said, introduced with 2 lines, I think you finished giving a kind of a moderate introduction to our work. And yeah, just 2 things to add. I'm the ambassador of telemedicine to the Karnataka India chapter and the ambassador of Global Telehealth Exchange. Also a volunteer at NHA. And I volunteer in multiple organizations with multiple NGOs, providing quality healthcare to people who are underprivileged and who can't reach us at the nick of time. So telemedicine to me is what I said, accessibility to quality healthcare. What happens is, that is what I would put it in 2 words or 2 lines, because patients who are deprived of quality healthcare because of the distance, when distance matters, telemedicine helps to cover that. As Mr. Jagdeep rightly said, that rural healthcare is part of the distance care, and having e-clinics and having clinics from the rural healthcare and helping people out there is really something what telemedicine should aim at, and in fact expand more in that particular project. And telemedicine is only live video conferencing and consulting the patients. Other part of it, whatever we said about second consultations and all that, that comes under telehealth. It's a broad perspective, like lab tests and pharmacy. That's all part of the telehealth program. Telemedicine is just consultation with the patient, bridging the gap, providing quality health care to the patients who are not with us physically and who can benefit from these consultations. That's what I would like to put it as, and thank you for the opportunity. Looking forward to the discussion.
Thank you, Dr. Haleema. Rajesh?
Thank you, Abhishek. First of all, congratulations to the entire PATH team for bringing this webinar together end to end. It takes a lot of efforts, a lot of background work to actually initiate something intuitive like this. And co-panelist, thank you for being on the same stage here. Abhishek ji just introduced me, and fortunately or unfortunately, I don't know, but recently the designation for me has been changed by the government. I mean, I belong to a government sector, and so I have two changes for Abhishek, for you as well. Now our department is not Health Informatics and Electronics Division. It is now Digital Health Innovations Department. That is now totally in sync with what we have been doing since the last 2 decades now. And also, so the joint director, now the government has given the new designations in CDAC. It is now scientist. So otherwise, as rightly pointed, we have been working in this domain for around more than 2 decades. For me, it has been a long journey, right from, taking the things onto my own hand in terms of implementing, going to the field where I used to interact a lot with the practitioners, the providers, the stakeholders, the end-to-end turnkey solution which we used to implement. And I have over more than 2 decades of experience in not only implementing India's leading telemedicine networks prior to eSanjeevani, then being associated with eSanjeevani for making it as a national telemedicine service. I have also had the privilege of establishing 4 overseas networks for the Government of India on behalf of the Ministry of External Affairs as part of the bilateral programs. Jumping right on to the definition of the telemedicine, just for the sake of records, the WHO defines it as the delivery of healthcare services where distance is a critical factor, using the IT and communication technologies for the exchange of information for diagnosis, treatment, etc. But for me, I would say now CDEX eSanjeevani telemedicine system has somewhat changed it to a more common, user-friendly, and very understandable definition. Just in one-liner, it is a free of cost consultation service where patient can connect to a doctor of his or her choice and get themselves the first level of consult.
Thank you. So, as when it comes to consultation, one of the important pillar other than the technology and platform is the healthcare provider. So, Dr. Haleema, we will like to know that since teleconsultation is getting more adopted, and in last 8-9 years since you have provided teleconsultation, that journey would be very different from moving from these traditional traditional consultation where you are sitting in front of patient and providing those consultations, moving towards this remotely sitting patients and providing those consultation. So what have been your journey like? How do you build that rapport? How that trust has moved from what it used to be? And also, can you shed some light and on your journey and your relationship with the patients?
Very beautiful question, very close to my heart. Yeah, when we start off with telemedicine and the first sector when we had before COVID, when I in fact initially started on moving on with telemedicine consultations, it was like a unexplored, unventured out sector. People were there. There were many, of course. Apollo has been the trendsetter. ISRO laid a path for telemedicine. So there were a lot of people who are already into the thing. But then doctors using it was a very big question mark at that time. And before COVID, everyone were very, very new to telemedicine and digital consultations and all that. The conventional way was thought to be the way of consultation, and the patient themselves felt that unless you are in front of the doctor has seen, touched your pulse, whether he felt the pulse or not is a secondary thing, properly or not is a secondary thing. But yeah, the doctor has to touch and feel the patient to for the patient to get the reflection of the consultation or to feel better. That was the myth, that was what was happening. So when telemedicine consultation started off, the first question I was asked by my colleagues is, what about the legality aspect? So do you have anything that proves that telemedicine consultations are valid and they can be considered as any other normal consultations? So my only answer was that unless you are not aware of what you are doing, and if you are not confident about yourself being a doctor, about diagnosing and treating the patient, don't venture out in the sector like this. So it requires a lot of expertise, lot of, I would say, clinical acumen to diagnose the patient on video consultation, and to kind of I would say help the patient out in the primary aspect, right? So when these things, the thing which became very easy after COVID was we had the guidelines which came in, which made legality very easy. We had the NMC recognizing telemedicine consultation. They gave us a very good platform. They told us the do's and don't, and what the doctor should do, or what they can do, what they can't do in telemedicine, which actually cleared up most of the gray area. So people when they were questioning, and when the colleagues had a lot of issues with what telemedicine is all about, the NMC guidelines brought a very clear margin to what telemedicine could deal with. So following that, it became very easy, more so because we had everything in place. We had many sectors who were opening up telemedicine consultation. We had people who were basically into or venturing out to telemedicine consultations, and the path cleared up much more. To me, still the basic aspect still remains that the connectivity could be an issue at times. The doctor's expertise can be a problem at times. And I always say in any of my talks that training is very important. If a doctor ventures out for telemedicine consultation, he should know what to ask. The call is usually for 10 minutes or maximum 15 minutes. So to elicit a diagnosis in that, even to have a provisional diagnosis in that, the doctor must be knowing what he is dealing with. How can that happen is by asking the right question at the right time. Some patients, I think most of us who are in telemedicine are doctors who know or who are watching me, they definitely agree with me that not every patient will give the history correctly. There are patients who don't tell us most of the most important things like drug allergy. If I miss out on that, forget about legalities. I mean, you are dealing with a life, right? It's very important for us to basically know what we are dealing with and what kind of questions we should ask. Don't depend on the patient that he will tell you everything. This is my advice to my colleagues who are venturing out in telemedicine. And I learned this over time. And initially, when we started off with telemedicine, we were like, okay, how do the patients have to they go on talking and telling they are not sure what is important, what is not. They tell me starting from the day they were born. So I should know how to decipher it, how to get the important points and all those things. So training makes a lot of difference. The physicians have to be trained. And this is what actually changed the entire look at telemedicine. For me, the journey was very difficult. The initial part of it was very difficult to basically, I would say, as I told you, the legalities, the questions by the colleagues, by the patient, why are you opting out to this? Why not a clinic? Physical clinic is much easier, much more convincing and much more nicer. But then when things moved on and COVID happened, when everyone went to digital space and digital consultations, and the thing just followed after that. So I'm really glad that telemedicine has found a way in sector like India, and which really needs rural healthcare. Thank you for the question.
Thank you, Dr. Haleema. So, Jagdeep, I think coming back to you on this, means you have been part of this as an entrepreneur. You have established a platform for providing teleconsultation, and you have seen it starting much before COVID. So when there was no COVID, the acceptance of digital was limited. So the perception was different as well. Can you shed some light and probably also put in some mechanism what you adopted to remove some of those perceptions, and what changes you saw post COVID as an entrepreneur, as a platform provider.
Thanks, Abhi. So again, let's start, with your pre-COVID question, right? So we started in 2014, 2015, right? COVID happened, so a lot of our journey has been pre-COVID. Completely echo with what Dr. Haleema said, right? I mean, the same challenges of getting doctors on board, ensuring patient safety, and so on and so forth. But we were very clear that there is a very clear need of access to healthcare. Either we produce 4 times the more doctors we need, or technology and digital is the way to go. So we are fairly clear that this is what it is. And even when we started out, and we met the some of our patients and customers, right, there was a genuine need that the nearest doctor might be 50-60 kilometers away, the nearest specialist might be even more further away. So we looked at acceptability, or what you said, or in 2 parts, right? One is awareness of telemedicine, and the other is acceptance of telemedicine. And I'm going to answer mostly from a consumer point of view, right? So if you are in rural India and the nearest doctor is 100 kilometers away, right, and if you are able to provide a decent quality service that is relevant for the customer, acceptance I don't think is a problem, right? If the service is good, right? If it really solves the need. But awareness became an issue, because awareness is like anything new, right? Awareness, it became a challenge. Like any public health intervention that we need to do, we needed to kind of do a lot of awareness campaigns, whether it is talking to the influencers. At every village we created a community of influencers and talked to them. We did the usual pamphlet distribution. We did the usual marketing campaigns to increase awareness, right? But telemedicine or any new concept, it was a concept selling. So it's just not that you can just give a pamphlet to somebody and say, okay, this is it, this is it. You had to actually explain the concept. The doctor is far away, here is how you'll get the prescription, and so on and so forth, right? So COVID, absolutely helped us, right? Because, we had no resources to increase awareness in the areas which was there. But when COVID happened, there was a huge awareness wave for everything which is digital, right? Digital payments, digital healthcare, and everything. So that did increase awareness. Acceptance, I still feel, is largely a factor of how good your consultation and how your patient experience is, right? And are you able to provide medicines on time in a model like ours, right? Or if the doctor prescribes a test, is there a diagnostic test nearby, right? So if you are able to solve the, what do we say, quote unquote, customer problem, that was the area, right? And again, post COVID, yes, the awareness, kind of, so we don't now have people who say, we have not seen anything like this, right? So they've heard about telemedicine. Then you need to kind of in a concept sell, and then make sure that your service is a way okay. It also happened that eSanjeevani came in, right, and it kind of scaled up. So people were also experiencing telemedicine or a model of digital healthcare on the public side. So it did give a credibility and a recognition of the concept itself, right? And I think that was a big boom also for the private sector, which we kind of really complemented that, right? In a way. So yeah, I think that's what it is. I think the awareness still remains a challenge, right? Although it is kind of much, it has increased. But I think that the true solution for acceptance is, are we able to really understand what a customer wants and then solve it, rather than, fitting what we think is the right solution, right? So the classical, social change kind of a theory. So yeah, that's.
Thanks, Jagdeep. Now moving on to from provider to private to public sector. Rajesh, we know that teleconsultation as a project has been part of CDAC's program for a while. It's not new. They have tested it out in different versions of it and different variations of it before COVID came, and Ministry of Health with this teleconsultation guideline also pushed launch of eSanjeevani's OPD version of it. And I think kudos to CDAC team. They developed eSanjeevani OPD in 19 days. So from the day they were asked to launch it, and they launched it in 19 days. So incredible work there. But what has been your journey of e-Sanjeevani, if you want to talk about? And as you said that you were also participating in implementation of e-Sanjeevani throughout. What has that journey been like from a public health perspective, where uh, the resources are not changing, but the mechanism is changing? Can you shed some light on that, please?
Sure. Thank you once again, Abhishek ji. As you are aware, CDAC being a scientific organization under the Ministry of Electronics and IT, we have been associated with the genesis of this technology since early, uh, rather late 1990s. Exactly in the year of 1999, we were interested with the task of developing Government of India's first indigenously developed telemedicine technology. That was way back in 1999 when the thought process was there that we must have a government's own solution for catering to the requirement in the public health domain of the government sector. So that was the idea when it was conceived way back in the ministry's level, and contrary to the expectations where everybody would believe that this implementation, or rather the development of the telemedicine technology in itself, will be the first pioneer telemedicine network. It was actually the not only the development of the telemedicine technology in itself. Sanjeevani was the name at that time. I don't think I need to explain the genesis of the word Sanjeevani, but that was the branding or the trademark which we created at that time. That was a desktop-based solution, and at the same time, apart from developing that telemedicine technology for the three key modalities, those were envisaged by the government at that time, would entail the uptake of teleconsultations in the modality of teleradiology, telepathology, and telecardiology. We were also interested with creating a network where once this telemedicine technology is adopted at the state levels, district level, by various stakeholders in terms of state governments, in order to create their own statewide telemedicine network, or probably a geographically co-located telemedicine where multiple states can make utilization from the expertise of the specialist available within the periphery of that region. So within the scope of the development of telemedicine technology, we created a national network of 6 premium hospitals where they were interconnected in between themselves, not only for envisaging or visioning the journey of telemedicine in the country, but also for the other spinheads associated with the telemedicine, that is the CMEs and CPCs as these are known, the clinical pathological consultations, or the continued medical education, where the specialists sitting at institutions like AIMS, PGI, MER, Chandigarh, etc., they broadcast the recorded lectures, their case histories, their experience to the MBBS doctors, interns who are more than keen to uptake this knowledge from their seniors. And then once this was established in the country by 2024, uh, after this national network, each node of these 6 premium hospitals like AIMS New Delhi was connected to spokes in Haryana. In Punjab, we had a statewide telemedicine network connected to the other specialty node PGI Chandigarh. So accordingly, these 6 nodes were selected by the government, so that once the state governments start onboarding this national network, they should not find difficulty in what is the key problem statement of the telemedicine still remains as on date. That is the availability of these specialist doctors. So that was the idea, and then from the national amalgamation of these premium hospitals in a single network, the uptake was trusted by the NKN implementation, where the national knowledge network was created, where in all the medical colleges in the country were interconnected. Um, Parallelly, while we were implementing the statewide Punjab telemedicine network, another key case study, which in the history of the government implementations is worth discussing or referring to as far as the initial success stories as well as the failure stories are concerned are these two networks. Punjab Telemedicine Network, established in the year 2006, and parallelly, right from rather 2005 till 2008, these two networks were established. So, as anybody would envisage that definitely in the Himachal, because the need and the geographical area, rural and remoteness, that uptake might have been more in that. Contrarily, it failed in that. That is the failure case in the history of implementation. Whereas Punjab, contrary to another assumptions that every 5 kilometers or 10 kilometers you have a good hospital where otherwise physically one can go and take the teleconsultations. I mean the physical consultations. But there, the prior to the eSanjeevani implementation, during the COVID time and post COVID time, the uptake or the success was the most popular was among this networks was the Punjab telemedicine case study, which was even taken up by the Prasar Bharati for a case study for showcasing it to the entire country. But that was the time, that was the initial time, and then even prior to the COVID, the government was envisaging as a policy decision to roll out telemedicine as a facility or as a feature with associated with the then health and wellness centers, now rebranded as the Ayushman or Arogya Mandir, where they wanted to enroll or offer 5 services, rather 7 initially. Telemedicine was one of them. So that was the year 2018, and between this 2008 and 2018, some silos networks were designed, developed by CDEC in association with various ministries, other line ministries like with NIC. We established a digitally inclusive and smart community network where we interconnected the leading hospitals with 100 spokes. We had isolated networks where even at Gram Panchayat level, we had implemented telemedicine as a POC in the Ajmer area. We even conducted a mega health camp where this POC was showcased, not only showcased, but health records were collected for analysis in terms of what features should be there in a generic telemedicine system, etc. And then between 2008 to 2010-18, the international implementations also picked up. But the game changer was the government of India's decision to select a common telemedicine platform for the entire country for rollout in the health and wellness centers in the year 2018. While this was being conceptualized by the government in terms of the features, technical specification, adaptability, etc., the plan was to roll out in the HWCs. But when in 2019 we did a national workshop calling all the state nodal officers to take their viewpoint on the envisaged features and the issues which they might face during the rollout of such network. During the end of 2019, the COVID struck in the world, and while we were doing this POC of eSanjeevani in the HWCs, we were forced to stop the implementation because the lockdown was announced in India as well in as early as March 2020, and that was the time when we were interested that okay, the HWC model was primarily the provider to doctor or the provider to provider telemedicine system, whereas now the need of the hour was where the patient, because the hospitals were locked down and even the normal consultations apart from the COVID for the chronic patients were not happening. So that was the time when the government decided that we should implement the patient to doctor modality immediately for the benefit of the people, as well as to avoid the spread of the infection further by the physical visits. And that was the genesis when eSanjeevani OPD was, as you said rightly, 19 days was the formal notification. We were told to roll it out as a pilot in the state of Punjab itself within a week's time. And that we did. I mean, the 19 days was the rollout for the entire country, and rest is history. I think I'll take more on the questions because I'm so much attached with Sanjeevani. I can keep on speaking endlessly for the rest of the day. So I think I'll
Sure.
stop here and I'll take on your next question, please.
Thank you, Rajesh ji. Yes, I think if we hear you and we can easily understand that the eSanjeevani's current form has seen lot of POCs, small and short POCs of different kinds before being converting into a platform which can be scaled up and see the version of it provide more than 75,000 consultation a day uh, on this platform, and all of that thing is happening. But going back to Jagdeep, like having a private teleconsultation platform, one of the success criteria normally considered for teleconsultation is that how the patient's care is being effectively provided in a similar mechanism to how a physical consultations, like if we kind of put it in one word, how the continuum of care is happening, how the follow-up happens. So first of all, I'm guessing you must resonate with the idea that we need to provide that thing. But can you provide some information or some examples how, as a part of Karma platform, you have implemented some of those ideas and maybe some use cases of how it had changed, like patients coming back on your platform? Some examples will support that.
Again, Abhishek, I think as we initially also discussed, right? I think the end objective is not only to do a video call, it is to treat a patient and provide service to a patient, right? We very initially already when we started, we realized that there will be a lot of back end additionalities that will be required, right, along with digital consultation. So we have a full comprehensive departments actually now within our organization that focus on various aspects, which I'll quickly tell about, to ensure, as you rightly said, continuum of care, right? So right from where the outreach happens, right, and then when the consultation happens, there are regular follow-ups, that we do over WhatsApp, and also in many cases, if people don't have a WhatsApp, telephonic reminders to come back and take their medicines, right? So if somebody is suffering from diabetes, right, in rural India, you have to also increase the awareness of, how do you treat diabetes, not just, by prescribing. So, we have a team, which is, either digitally or telephonically calling people and doing that. We have a very stringent NPS mechanism that we have started. So, patients can actually rank the doctors, rank the facility, not really clinical, but rank, the service offerings that they have. We also, over time have triaged patients, right? So not all patients require same level of monitoring, right? So depending on the risk of the patient, depending on their clinical history, right, there is a different level of triaging that happens. So if a patient is, a high risk patient for a particular disease, their response or our response of follow-up and monitoring will be different. For certain diseases where follow-up might be, not as stringently required, it is there. One of the key complaints we have, when we receive patient feedback is that, I did not get better. And when we actually looked at our data, 70% of the time the answer was that they did not even take the medicines on time or take the medicines as prescribed, right? So there is a lot of focus that kind of goes in after the doctor has consulted to provide counseling as well as support to the patient that we do. We now also have a dedicated quality assurance team. So actually in our team we have less doctors but more people who are actually looking at this on the back end, right, who are actually kind of making this magic to happen, right, and that is where ultimately once you do that, that's when the actual need of the patient is solved, and that's when the patient will say, okay, my problem is solved and I am willing to come back again, right? And for a private provider, it is important that the patient comes back to us again, right? And this again, from a public health standpoint, you are able to monitor disease, you are able to see disease progression, improve health outcomes, right, and thereby generate impact as well. So these are some of the ideas that we look at.
Thank you, Jagdeep. So while we are seeing, as we have already heard on the present and past probably of the telemedicine, we also should discuss how the future should look like. And I think my question should go to first Haleema for you. That how do you see telemedicine panning out in future? Because as we already have accepted the fact that people are accepting telemedicine as a program for consultation, but how telemedicine can be leveraged for more critical kind of approach where it can be used for either disease management, or how it can support this universal health coverage for India? So can you
Yeah,
provide some inputs on that, please?
definitely. This particular, I would say the future of medicine or telemedicine depends on the devices now which are attached to telemedicine. Once we have a live video conferencing, there are many more devices which are involved to give a good experience and to get the diagnosis in a proper way. Like digital stethoscope is there is otoscope, there is endoscope, there is dermoscope. There are so many devices wherein if I sit here, I can hear a heartbeat of a person maybe who is 4,000 or 5,000 kilometers away from me, who is not even anywhere around. So that would make a lot of difference. That's already made a lot of difference to the quality of care. And implementing that in routine consultations would definitely make a lot of difference in the future of telemedicine. Then we have telemedicine or remote monitoring being used in remission of diabetes. I would not say it is a reversal, but yeah, remission of diabetes. So when we have the CGM patches working on the patient, recording the sugar in and out, recording the sugar when the patient is sleeping, when the patient is eating or had a particular meal, the fluctuation of sugar that is happening on and off, that will help the doctor to prioritize the diet and to give a proper diet chart, a proper kind of I would say food priority or food chart for the patient to make sure that his diabetes gets under control faster. Control to such an extent that the HbA1c normalizes with diet and physical activity. That is possible because of remote monitoring again and telemedicine consultations frequently. So this is one of the parameters which is already ongoing. So improvising on that would definitely be the thing to do and the thing of the future. There is smartwatch which is happening everywhere. I think everyone just gives a call with the smartwatch on, and I get a call suddenly that my heart rate has gone to 200. So is the device enough? No. We have to even have a clinical expertise or clinical person deciphering the devices there and telling them that it's not always that you have to panic. He could be running, he could be jumping, and his device might be jumping with him. And he gets worried about seeing the rate there or seeing the number there. A doctor reading those numbers, or doctor who was empaneled with the I would say technology provider, would be a thing of the future. That's one. And the third thing would be that using the technology in a proper way to help critically ill patients. We already have tele-ICUs in place. There is a command center which is monitoring tele-ICU. There are certain patients who could be neglected during the rounds, or maybe the doctor, ICU doctor. I'm an intensivist myself, a profession, and diabetologist and intensivist. So ICU doctors are so busy that at times they tend to neglect certain reports, or it's very difficult to get back and see each patient in person. That time, if you have a video consultation on, or if you have someone who has your back, someone who's monitoring the patient when you are not around, or when you could have missed something, is a big boon in critically ill patient and telemedicine and tele-ICU. So tele-ICU, tele-diabetology, and I would say tele-speciality of telemedicine is the thing of the future, using multiple devices. Devices wherein you can, in fact, see the patient through and through. There is now a face scanner which has come in. The patient only has to log in and look into the scanner. A doctor gets the vital signs on the other side. The moment I say hello, I can know the patient's vitals. I can know what is his heart rate currently, his saturation, it makes things a lot easier in telemedicine. Because I can give you an example. A patient calls me up with fever. Okay. He just says, I have upper respiratory infection, I have cold and cough. When I ask him about the fever, the response I usually receive is, Doc, I touched and saw, it is not hot. I'm okay. But I want to quantify that. For me, not hot or having a fever is very different. He may have hot flashes, or you might be feeling bad, unhealthy because of the upper respiratory infection. Whether he has a spike or not is very essential for my decision. How do I know that? A thermometer, again, a remote monitoring device, which is the old one, but definitely used and very user friendly, and it is required. So that can be monitored through a facial scan, which is very essential for me to make a decision. So I can say, yeah. And when I tell them to put the thermometer on and tell me the reading, they say, okay, oh, sorry, there's some 99 degrees temperature. I didn't think it is fever. So for them, the reading could be different. For me, it could be decision changing or decision making. So having those things in, I would say, at hand during the consultation would make a lot of difference. And the future being the face scan giving the vital signs, the face scan giving us all the information or all the numbers that we want during the consultation is going to make a real change in telemedicine consultations. And I think getting the diagnosis proper, getting the treatment online is very important from the patient and the doctor point of view. Assisted by devices would make a huge difference. So new devices which have come in will make a lot of change. And I see the telemedicine will definitely prosper and grow in the future. And education is a second tool, which is very, very important. With the devices and with the expertise, educating doctors and telling them more about telemedicine and talking to the patients also and telling them that this thing definitely works and it helps. Re-emphasizing the priority is very, very important. So I think all these things put together would make telemedicine a thing of the future, present and the future, definitely. Thank you so much.
Thank you, Dr. Haleema. Means I know we are cutting close to time, but there are two important questions, one from Rajesh and one from Jagdeep, we shouldn't miss out. So the first question to you, Rajesh, means Dr. Haleema did talk about these medtech technology, and the second good important piece is AI, which everyone is talking about now. So as a public platform, public teleconsultation platform, eSanjeevani, how can you set some important facts what eSanjeevani is trying to do or leveraging AI for what features to make eSanjeevani support the UHC use cases?
Right. eSanjeevani already utilizes the AI to the extent where nobody feels, that because the biggest challenge in the adaptability of AI-driven solution is the very resistance from specifically the doctors themselves and also the technicians at some time, and even from the patient perspective, the usability aspect, they feel that the technology should be easy. It should not drive them in the sense that they should feel that they are using a very heavy tech-enabled solution. So eSanjeevani uses the features of AI, the functionalities of AI to the extent where it is so common that for example, in the previous version, the eSanjeevani 1.0, which we have launched, we had a mechanism where the patient would register, key in their medical health records and other consultation related data, and then get teleconsulted with the doctor. So the first intervention in eSanjeevani is the symptom checker, which was made a mandatory feature recently, just to enable the doctors to make a more informed diagnosis in terms of the differential diagnosis. So once the patients register themselves, select some questions on the basis of the current symptoms for which they have initiated the teleconsultation, the symptom checker suggests the doctor at the other end the probable differential diagnosis. That is the first level of intervention. But then, having said that, at the same time, the doctor is still free to pick the provisional diagnosis or the confirmed diagnosis from the list of the standardized SNOMED CT nomenclature, which is anyways available in the system. But I see the integration in the sense that in case, as Dr. Haleema very correctly pointed out, that at times the patient don't intend to give the right information, or they would hide some information, would make something difficult for the doctor to choose. Here the symptom checker is so intuitive that in case they are I would say bluffing or keying in the wrong answer, that would automatically suggest to the doctor in terms of no differential diagnosis that the patient is not, probably presenting their right symptoms. In case they are providing their right symptoms, then only the AI algorithms would throw the differential diagnosis. That is the first level of intervention. Then at the second level, we are taking it a step further, like we have seen in the both of the modalities, the assisted telemedicine, where the patient is assisted by the CHO, or the patient themselves drives the consultation in the patient doctor modality. There they are not clear once they are landing into the system, even if the system is so simple to use, that which specialty or which modality they should be consulting the doctor to. So a headache or a stomach ache might be referring to, to a general specialty or general medicine one, but it could be in the longer once the diagnosis and prognosis is made, it could lead to certain specialized line of treatment which he or she might require. So based on the data that has been uploaded by the user, rather the patient, or on behalf of the patient, and the question and the answers to the question which the symptom checker has provided, the system would automatically, on the basis of the AI driven algorithm, would suggest which particular specialty or which particular OPD the patient should be consulted to. And then in the longer term, once we get the ample data for the AI algorithms to train to a level where the accuracy, because I would say as on date, the accuracy is something between 55 to 65%. So we need huge data in terms of the qualitative assessment for the algorithms to come to a level where after this it can be taken up for interventions in the medical adherence. But that would be the next level, probably 2 months down the line. And the third intervention which is being done, that on the basis of the interaction, if you have heard about, like, the Sanjeevani is currently hosted on the Azure platform, so we are using some inherited or the cloud specific capabilities of Azure, like the Copilot, to come up with a speech to speech enabled diagnosis, or rather the speech to speech enabled analytics, I would say, not the diagnosis, where on the basis of the interaction that has been done between the patient and the doctor, on the basis of that interaction, the key medical words, the terminologies used, it would generate a summary in terms of the, again, the key highlighters, which would help the doctor in analyzing and deciding the case and the line of the treatment. Apart from that, the medical once the medical consultations get completed from patient's perspective, that he have explained everything to the doctor. So in terms of differential diagnosis, even the medical classification in terms of what medicines, not the exact salt name or the exact medicine, but the classification in terms of that anti-allergic. I mean, I'm bad in the terms of the medical terminologies, being a technologist, but in the classification in terms of what category of medicine needs to be given to the patient, that categorization also the AI presents, provided that ample data has been uploaded by the patient in terms of his past and the current ailment to which he is teleconsulting with the doctor. So that is one ecosystem which is already there in the eSanjeevani, and parallelly we are working on two immediate spin-offs of the AI-enabled solutions, like the other panelists, co-panelists have shared, that it can be used for remote monitoring. So there, apart from remote monitoring, we are targeting specifically for the tele ICU, where the AI-enabled tele ICU system will not only monitor the ICU readings of the patients remotely, but would also generate alerts to the healthcare teams in terms of the changes in the current condition, or the optimization that might be required for the critical care delivery. The another intervention, although not yet started, is the tele rehabilitation, where we had tied up with the All India Institute of Physical Medicine and Rehabilitation at Mumbai, where it is just in the project proposal stage as on date. But we, as is part of the project proposal itself, we have envisaged AI-driven tele-rehabilitation platform to provide remote therapy and monitoring of the patient. Those are recovering from injuries, surgeries, and chronic condition, in order to improve the accessibility to the rehabilitation services.
Sure. Thanks, Rajesh. So yes, as we are coming close, so Dr. Jagdeep, I will try to combine two questions, one from the audience and one of them which I had. So, how do you enable accountability with all these medical technologies and new technologies coming in? But there need to be a certain level of accountability to, as a service provider, to doctors and nurses who are providing those services. So how do you do that? And is there B2B opportunities for telemedicine in India?
Mhm. Cool. So thanks. So for accountability, I think the benefit of telemedicine is it's all digital, right? So and digital then enables a huge level of transparency, right? So we have a patient and a doctor consultation, which is done on a video. There is a prescription. So and everything it gets recorded, right? So a key question in telemedicine is waiting time, right? So how quickly has the doctor responded to the patient? What is the quality of the video interaction? What is the length of the video interaction? Have you done enough counseling? Right now, in a digital platform where all of this is digitized, getting that data is easy because it is all digital. And therefore, once you actually can create, systems around that data and then create proper incentives, right? I think enabling accountability is very easy, right? So in classical cases, you have seen, you might have heard about private hospitals, incentivizing doctors on the number of patients that they see and the number of revenues that they, right? In case of telemedicine, you can actually, and we do that, you incentivize on quality parameters, right? So we will incentivize on NPS, we will incentivize on how accurate your prescription was. We will incentivize on how, what is the quality of documentation you have done in the prescription. So again, because it is digital, I think, the data then enables us to create so many opportunities of enabling accountability at the nurse level, at the patient level, as well as at the provider or a doctor level. In terms of the question on B2B, right? So I think B2B means different things to different people. So for us, B2B is if we leverage our technology platform or our capabilities, which is largely a network of doctors we have, and our technology platform to other like-minded healthcare facilities, right? So for example, there are certain non-profit organizations that are in rural India. They do great work, but they do not have access to doctors, right? So they then leverage our platform as well as, in many cases, the panel of doctors that we have, thereby increasing our reach. So we being a physical provider, right, can open only so many clinics, right? So our B2B opportunities are that we kind of collaborate with like-minded organizations, right, and enable B2B. But again, B2B means different things to different people. So I don't know what exactly the definition that the person who's asking is, but I am hoping that I was able to answer that.
Sure. Thanks, Jagdeep. As we are almost towards the end of time, one important question which has come across was, what are the key considerations consumers should evaluate when choosing a telemedicine platform? So any of the panelists, if you feel like answering this question. Yeah. So as a consumer, what should be the key areas or key importance of a telemedicine platform one should choose?
So maybe, I can take that,
Sure.
right? I think, again, it really depends on the need, as I said, when we speak about consumer in pure marketing parlance, it's about, what is the need you're solving, right? So if my need is that I am, it is 2 a.m. in the night and I am having a chest pain, right? Then you cannot come to our clinic because it is closed, right? So then you need a telemedicine platform, which is more handheld, which is more remote, or maybe you need a telemedicine platform, which is more tele ICU or emergency based, right? If my need is that I have an acute illness, right, which I need to get treated and the doctor is far away, then you'll probably use a facility based telemedicine clinic like ours, right? If my need is that, okay, I am having something but I don't know if I should go and see a doctor, then I'll again use a mobile based system, right? If my need is that I need to go to a public healthcare provider, go and see to this thing, then I'll probably go to the public healthcare system and then probably take consultation from me Sanjeevani, right? So I think it really depends, and there are multiple options of telemedicine, and a lot of it that has been discussed, right? And I think one has to really look at what are the offerings of each platform or each model, and then see how it fits into that, and it will change, right? There's one more question which is there about old age telemedicine, right? And that's kind of a very, very big gap, which I think there is a lot of innovation that will happen. So again, it will depend on exactly what the need is, and then we start from there.
Thanks, Dr. Jagdeep. And while the telemedicine itself is a topic which probably if we can continue discussing it, 1 hour is never enough. There are so many aspects of it, from technologies to pieces to service delivery, to the future forward looking mechanism of it. How new set of, like Dr. Haleema talked about, how medtechs new upcoming, and there are so many startups working amazingly on these new medtech devices which can provide instant reports and data. These point of care devices, if integrated with eSanjeevani, has been already doing, then improve the quality of care provided by telemedicine. But again, while 1 hour was not enough, we did touch on some of the important aspects of telemedicine, that how it has evolved and how it is helping in India and probably in different platform format across the globe into achieving UHC. And thank you very much, all of our panelists, Jagdeep, Rajesh, and Dr. Haleema, for the time you have provided. I know many of the audience will still have more questions. If you have any specific questions, you can email it to us from on the YO.DH platform. And we will probably pass it on to our participants, and hopefully we'll be able to answer some of those questions in future. But any last word from our panelists before we close off the session?
I have typed an answer to one question out there. They were asking about licenses and all that. So I have given details on that. And yeah, the last word for me is create awareness about telemedicine to patients and doctors alike. And if doctors have any questions or anything how to practice telemedicine, they can definitely, there are many courses available if you want to go through the courses as well. And of course, you can contact me as well if you want to know what exactly it is all about. And training, without training, I would say don't attempt telemedicine. It will be very difficult to diagnose as well as to have a provision as well. So I think create awareness and let the patients benefit from this. And there are many people who out there who need medical help on time. And it's very important for us to reach there since we can't go there physically for each patient. Digital space is created a lot of opportunities. So I think get the patients on time to the doctors who treat them. Thank you.
Thank you.
I'll also take up a question pertaining to the challenges of telemedicine specifically mentioned for eSanjeevani at the ground level. So yes, these are very well-known known challenges, and I think now eSanjeevani has matured to that level. Just at least from the technical aspect of it, we have addressed at least two of the challenges, like the increased waiting time, which is mentioned in this query. So like in 1.0, we had only mapped the user from the registration data to that current state itself only. So in terms of the accessibility to the doctors was restricted to that state, and also in case they are available, that too a long waiting time was there. Now the shift in terms of the functionality itself is there, irrespective of your state of residence. Once you are a registered user in eSanjeevani, you can connect to any of the doctor across India, thereby reducing the real time. And also we are showing now the availability of doctors in real time, where you can see which doctor is active, which is idle, and which is currently busy in another call. So the other are mostly the administrative aspect of it, but yes, we have tried to address those in terms of like in the earlier version, until and unless a CHO would have a sitting space all in one desktop or a laptop, only then he can facilitate at least the assisted model of telemedicine. Now with the eSanjeevani app in 2.0, the integrated app, we have the functionality where the entire suite of application, right from the registration of the patient to the end-to-end teleconsultation process, is enabled on that telemedicine app itself. So at least the infra level challenges is addressed. But yes, I mean the Wi-Fi for the recharge, I think that is something which the state administrative authorities have to take care. But we will surely try to figure out something, if anything can be, from technology side, if some intervention can even be done to address any of these, surely we would work towards those.
All right. So thank you, everyone. Thanks for being here. And as already mentioned by Pallavi in beginning, please join our community, youth community. It is aimed for youths to learn more about different aspects of digital health, but also collaboratively work towards helping the society and global aspects leveraging digital. Uh, and as digital is only the enabler of health, it is not health in its on its own. So let's work towards improving health and achieving UHC for everyone. Thank you.
Thank you.
Thank you. Thank you.